Hello, good evening. Welcome to the second of the August Seminal 6 series of webinars on important issues in upper GI surgery. It is my pleasure to welcome tonight Professor Danwent Gomez, a distinguished hepatopancreaticobiliary surgeon and professor from Nottingham University. He's going to be giving us a talk on the current developments in the field of intrahepatic cholangiocarcinoma and evolving strategies shaping patient care. The chat function is disabled for all participants, but if you do have questions, please can you put them in the Q&A. I will monitor that throughout the talk and we'll be able to have questions at the end. And without further ado, over to Danny.
Good evening. Thanks, Emily. Thanks to all the participants who have joined us on this cold Wednesday evening. So I'm here to present my talk on the management of intrahepatic cholangiocarcinoma. I'm going to go through the evidence that we have now in our latest guidelines, and also the challenges we face as clinicians when we are dealing with these patients with this aggressive condition. So a bit of a background. So 10 to 20% of cholangiocarcinomas, the subtype is intrahepatic. Now, there are other more common cholangiocarcinomas, which is the hilar cholangiocarcinoma and also gallbladder cancer, which is included as part of the biliary tract cancers. 20 to 25% are found incidentally, usually from imaging that is performed for other medical conditions. Unfortunately, most patients present at an advanced stage, and 70% of them are unresectable. In the surgical group, the 5-year survival rates are up to 30%, and these are your best comers. This is just a diagram about the types of biliary tract cancers. We're going to focus today on the intrahepatic cholangiocarcinomas, which make up 10 to 20% of all bile duct cancers. As you can see from this diagram, there are usually 3 types, which is mass-forming, periductal, infiltrative growths, and intraductal growing cholangiocarcinoma. So I just thought I'd present a case study. This is one of my patients who is a 36-year-old lady, presented with upper abdominal pain, and obviously the first diagnosis that came to mind was whether this was gallstone related. She had an ultrasound scan which picked up a possible mass in the liver. This was done in the community and referred to us. We performed a CT scan. I've just taken the selected slices of this imaging, which is showing a tumor in the right lobe of the liver. As you can see, it's involving the right inflow. And if you look at this coronal slice, you can just see the tumor here, which is extending quite a bit towards the superior part of the liver. Then we get an MRI scan, and once again, this you can see this tumor here on the right side, which is involving both the right hepatic artery and the right portal vein. So we discussed it in our HPB-MDT. All of us agree that this is an operable lesion, both on CT and MRI. And the plan documented in the MDT was to review in clinic and offer surgical resection. So we take the patient for surgery, and as you can see, this is the intraoperative finding. As you can see, this is a large tumor here, but this was not really seen very well on the actual CT or MRI, but intraoperatively, it looks like patient has got satellite nodules. So we then go ahead and perform a portal lymphadenectomy. As you can see here, this is the bile duct. There is a portal vein at the back, and you can see the common hepatic artery here. As you can see, all the lymph nodes have been stripped down, and we've done a portal lymphadenectomy for this case. We also then resect the tumor. So we did a formal right hepatectomy, and This is just the image of the remnant liver that has been left behind, which is essentially segment 2, 3, and 4. Initially, we thought it was small for size. Now, histology-wise, it's come back as a moderately differentiated intrahepatic cholangiocarcinoma. And as we demonstrated surgically, there were multiple lesions seen, and it was reported as PT3 and not. Our nodal yield is 13 nodes. I just thought I'd bring this up now as we can explain later in the talk. And unfortunately, the resection margin was R1. Now, in the follow-up period, she was discharged, did not have post-hepatic liver failure at all. But unfortunately, she was readmitted a week and a half later with a collection, and she had ultrasound-guided drainage. She was referred to the oncology following MDT discussion, and she was offered single-agent capecitabine. Unfortunately, she had recurrence at 9 months. Now, she's been under the oncology since then. We started first-line treatment for recurrence, which the current guidelines are cisplatin, gemcitabine with targeted therapy development. Unfortunately, she did progress under that, and we have started her on another targeted therapy. At present, she is currently alive at 30 months, and the most recent CT scan performed this month shows her recurrence in her liver are stable. She only has liver-only recurrences. So the big question here is, how can we improve management of this case? I'm just using this as an illustration for what the current guidelines say. So there are two guidelines which are worth a read. The first is the ESMO guidelines, which I think was published in 2018, 2019. And this gives a really good practical guide on the management of cholangiocarcinoma. And more recently, we have got the BSG guidelines, which is UK-based. It's a real good read, very detailed, and the management is based on subtype. So how are we doing in the UK? Are we actually following these guidelines that have been in place? So if I look at the key recommendations of these guidelines, there are many, but I just want to focus on four aspects because these four aspects are very relevant to us as surgeons. So the first one is the preoperative staging. As we know, we've got to determine whether patients are resectable or unresectable. And if you look at both these guidelines have emphasized that all patients, besides a CT and an MRI scan of the liver, they should undergo a PET scan. The other key recommendation is if we are going to perform a liver resection, we should aim for an RO margin, and all patients should undergo a portal lymphadenectomy if intrahepatic cholangiocarcinoma is suspected on imaging. And following surgery and post-operative recovery, these patients should be referred to oncology to undergo a period of adjuvant chemotherapy. So these are the four key recommendations, which I think are extremely important for us surgeons who are dealing with these patients. So in the UK, do we adhere to these guidelines? Do all our HPB centers actually follow each of the guidelines that have been recommended? So we have got two studies which we have done, two national studies. So the first study was our UK ICCA study, which incorporated the years 2014 to 2018. Please bear in mind, BILCAP was published at the end of 2018. So prior to that, single-agent capecitabine wasn't recommended routinely. And then our second study is the CAP-BIL study, which went on for 2019 to 2022. Now, the first study has been published in the BJS, and our second study, we have sent revisions to the BJS, and hopefully it will be published shortly. Now, in terms of preoperative staging, what does the current evidence say about performing CT PET. Okay, so traditionally, this has been used selectively. Now, if we look at our studies that we have done on both the cohorts, what is very clear, it is still being used selectively. So not all HPB units are doing this as a routine. Now, there have been many studies which have been performed looking at the importance of PET scan and whether they change the management of the resectable cases of intrahepatic cholangiocarcinoma. So there was a very good paper by Lamarca et al., which showed that up to 25% of all biliary tract cancers management were changed by doing CT PETs. A more recent meta-analysis showed that the PET scan is actually really good for staging lymph node disease, especially in the porta area, and identifying distant metastases. And is also good at detecting recurrences following surgery. Now, if we look at these two indications, they are mainly to determine whether there's extrahepatic disease. Now, the question is that does it really contradict surgery? So if we look at why it's being used selectively, is that does it contradict surgery or does it alter the surgical approach? Because fair enough, if you have lung mets, you will contradict an operation. But if you have one or two solitary lymph nodes at the portal area, which you will resect when you're doing a lymphadenectomy, would you contradict surgery? So that is one of the key reasons why maybe CT PETs are not being adopted as a routine for patients which we deem resectable following a CT and an MRI scan. So if we look at our study now, you can clearly see that in the centers that the light blue is the earlier cohort and the latter cohort is in the dark blue. What is very clear that in most centers, the usage of PET, CT PET, have clearly increased in comparison for the two-time period. So you can see that there is some adherence to guidelines, but unfortunately, when you look at the total number of patients who ended up having a resection that underwent PET, it's just over half the amount. So there's clearly still work to do to get more people to perform PET scans. Now let's move on to the liver resection part of the management. So there has been lots of studies showing which is the best approach, whether you should have an anatomical approach, for example, right or left hemihepatectomies, or do you do non-anatomical approaches, which is non-anatomical resections or segmental resections. So I guess the approach here would depend on the tumor location. Peripheral tumors are easily resectable using a non-anatomical approach. Tumor size, the larger the tumor, then it's unlikely a non-anatomical approach is going to be satisfactory. So a more formal anatomical resection like a right hepatectomy would probably give you an RO margin. Most of the studies now have concluded that irrespective of the approach, the focus should be obtaining an RO margin. That is very clear in all the studies now, that a clear margin is likely to be a prognostic indicator for survival. However, if we look at our two series that we have compared, again, clearly we are getting better in obtaining RO margins. And if you look at, for the purpose of this talk, the light blue represents the older cohort, 2014, 2018, and the dark blue is the latter cohort, 2019 to 2022. As you can see, there is an increase in most of the centers with regards to margin. However, in certain cases, we are still not obtaining a clear margin. However, this would indicate there's room for improvement, or it may indicate the tumors are actually quite big, or there may have been multiple tumors that one of them ended up having an involved margin. So obtaining a clear margin is clearly important. However, what about lymphadenectomy? So this is one part of the operation where the jury is still out there. So if we look at the current guidelines suggest that there should be a minimum of 6 or more nodes obtained from the lymphadenectomy. There's also been multiple studies suggesting which is the most appropriate lymphadenectomy to perform. Most would agree that the portal lymphadenectomy and going up to station 8, which is the cystic node, which is the common hepatic artery node, is sufficient and should allow you to obtain 6 or more lymph nodes. Sometimes the retroduodenal nodes are also sought after. However, the extent of lymphadenectomy seem to be surgeon dependent, whether a surgeon will perform it or not, and the extent it will perform it. The second is, what's the center's practice? In some centers, we found, from our study at least, that there are some centers which do not perform lymphadenectomy. It is extremely rare they would perform lymphadenectomy. They may only perform lymphadenectomy depending on seeing intraoperatively that the nodes are enlarged, or there may have been a PET scan which have shown the nodes are lighting up. And one of the problems with our study, which was a big limitation, was in terms of assessing the PET scan, was we don't have the number of patients who underwent PET that was then subsequently declined surgery because we found mets elsewhere. So what we could see here is that we don't have the diagnosis of what did the CT or MRI suggest this tumor to be, because it may have been that the MDT didn't suggest that the tumor was actually an intrahepatic cholangio. They may have said it's an indeterminate lesion for which they resected, and hence at that time, intraoperatively, there wouldn't have been an indication to do a portal lymphadenectomy. So the radiology preoperative diagnosis is important here. So what we found was, looking at our cohort and also looking at studies elsewhere, is generally there was a poor uptake. If we look at the American series from the SIR database, you can clearly see that the uptake was extremely poor. If we look at our most recent meta-analysis, what we found was that portal lymphadenectomy was safe to perform. There was no increase in morbidity. However, there was a variation in practice. There is clearly a practice which is not routinely performed, and hence it may be dependent on the surgeon, it may be dependent on the local practice. Now, what do we know from lymphadenectomy? There has been no study to suggest lymphadenectomy actually provides benefit for survival. What we have seen is that it will provide prognostic indicators. So it will tell you whether the patient has got lymph node disease or not. And if they've got lymph node disease, then their disease-free and overall survival is likely to be shorter than someone who does not have lymph node disease. So it's mainly used as a prognostic marker rather than being benefit for survival. So if we look at our two cohorts again, as you can see that the lymphadenectomy rate did significantly increase when you compare the two cohorts. There are some departments in the country where the lymphadenectomy rate is, above 60%. However, the majority of them are below that. But there is still been an increase that we can see, but it's still below the 50% mark. So this is something we can improve as a nation. Now, moving on to one of the most important parts of the management of cholangiocarcinoma, which is adjuvant therapy. So if we look at what is the evidence, so in terms of cholangiocarcinoma guidelines, we have very few randomized controlled trials. However, we have the section on chemotherapy, where we have two published randomized controlled trials. One is BILCAP and one is the ESCOT study. And both of these trials have shown that there is an improved overall survival. However, like all cholangiocarcinoma studies, there are limitations. And the biggest limitations of these two randomized trials was that it was not powered for subtype. So we included all patients with biliary tract cancers. So you have your intrahepatic group, your hilar group, gallbladder cancer, and distal. And hence, it's as we always say, you cannot compare apples and oranges, because now we know that biliary tract cancers should be treated specifically based on subtype. However, the general consensus is that adjuvant chemotherapy does provide survival benefit. And more recently, the long-term follow-up data of the BILCAP trial has been published and reaffirms the survival benefit. There has been the ETHICA trial, which has been done and completed, which is currently at the write-up stage, and we will know more about the role of adjuvant chemotherapy following the ETHICA study publication. Now, if we look at the UK, what our current practice is, what is very clear is that we have seen a big increase in the use of adjuvant chemotherapy. As you can see, we are nearly 70% now. If you look at the latter cohort, if you look at the 60% cutoff, majority of centers are in that group. So majority of centers now are referring more patients for adjuvant chemotherapy. It could be related to the recommendations of the BILCAP trial. Interestingly, most of our patients have undergone single-agent capecitabine in the UK. So if we go back to the first case study that I presented to you guys, there is room for improvement. So in terms of adherence to guidelines, what did we do well? So we did CT and MRI as an initial staging. We did perform lymphadenectomy. And if you remember, our lymph node yield was more than 6. We had 13 lymph nodes. We also referred the patient for adjuvant chemotherapy. And one of the part of the guidelines is that we should survey patients. And if we find that they have recurrent disease, we should refer them for further treatment under the oncologist. And we have done that. And hence she's still alive at 30 months, despite having recurrence quite early on at 9 months. So what can be our room for improvement? So we should have maybe performed the CT PET. So back to that question, which I told you, that if somebody has solitary or a couple of lymph nodes lighting up in the portal area, would you decline this patient's surgery? Or would you still take the patient to theater, do your liver resection and portal lymphadenectomy? I think this is one question which is quite hard to answer because we don't have good evidence to suggest either or. Now, we failed to obtain an RO resection, and I think sometimes we've got to make an intraoperative decision about how much liver we are planning to remove. Not all patients have a big left lobe if we're going to do a right hemihepatectomy, so we just got to be aware of post-hepatic liver failure. Now, what are the challenges do we face in cholangiocarcinoma? So I think I've been through the evidence bit, And now these are the challenges and what we should do in the future. So I think the biggest challenges we have with cholangiocarcinoma is there are patient factors. So our demographics is not necessarily something we can compare necessarily with the Eastern experiences who have better, larger data sets. Obviously, they have different practices than us, but we have different types of patient factors. So our patients are generally older. Our patients have more comorbidities. Now, we have introduced prehabilitation programs to help get our patients' fitness up, to help us with surgery. But sometimes this is still not quite enough. If you're somebody in your 70s, I'm not so sure how much prehab can increase your fitness by. So there are lots of patient factors which also sometimes, even if they have resectable disease, we may end up sending them for chemotherapy rather than offering them an operation. Disease biology. Now, there's something about cholangiocarcinoma where we cannot mimic our experience from colorectal liver mets with cholangiocarcinoma. Cholangiocarcinoma is an extremely aggressive disease. This condition does have a majority of them who present to us are already in an advanced stage. So most of them are unresectable. So essentially, we are trying to help maybe just a small portion of patients which we think are resectable. And then even after doing that, they still have a high level of recurrence. But the key thing is in our resectable patients, two things we got to look at is first, we got to make sure they leave hospital. And one of the problems with major liver resection is sometimes the future liver remnant can be quite small and they develop post-hepatic liver failure. And sometimes the mortality rates are high from that. So it's something to just be aware of. The second is adjuvant therapies. And this is something which we need to keep developing. So as I explained earlier, patient factors, we talk about the fitness for major surgery. Majority of them are more than 65 with comorbidities. One of the things with prehabilitation programs, I cannot emphasize enough that we definitely need psychological and nutritional supports. Most prehabilitation programs just focus on the exercise bit, and the psychological aspect is neglected. And actually, if you speak to these patients, they go through hell. It's a marathon which is never ending. So their patient journey is long and feels never ending. And a lot of these patients also nutritionally tend to be depleted. Not so much the intrahepatics, but it's usually the distal patients who present with jaundice or the hilar patients who present with jaundice. So they definitely need nutritional support. So never forget, this disease is aggressive. A lot of us now think that surgery may be disease modifying because the recurrent rates are so high. If we talk about the case I've just presented, clearly she's not cured. She reoccurred within 9 months. But what if, looking at such a large tumor she had with, multiple mets, would she still be alive if we didn't do the liver resection? So, we probably have modified the disease. Yes, she did reoccur earlier, but we have modified the disease and we have bought her more than 2 years now. I do appreciate she's also under adjuvant treatment and currently treatment for recurrent disease. So what limitations we have as a surgeons, just never forget the future liver remnant, okay? There's no point doing a fancy big liver operation and the patient dies of post-hepatic liver failure. I think this is one article I would say if you want to read up about future liver remnant, this is quite a good article I found. It goes through quite a comprehensive review on it. Now, one of the things we have seen from our guidelines is we do recommend adjuvant therapy. And never forget, all the operations we do, it's like being knocked by a bus. So these patients do lose a bit of their fitness, their quality of life, and obviously their performance, So their performance status following surgery is important because if they're not fit, they may be declined adjuvant chemotherapy. And actually, the surgery plus adjuvant chemotherapy bit, They are both treatments which are crucial for improving the overall survival of these patients. One of the biggest problems we have, unlike breast cancer, for example, or colorectal cancer, is we have a limited selection of adjuvant therapies. And that is something that is still a problem. We are still a disease which is poorly researched. We have still not had any decent trials yet published on neoadjuvant therapy, although there's one currently going on. We have not found really the ideal chemotherapy agent that is suitable for all patients. However, never forget now we have got targeted therapy. So durvalumab has made a big difference in our cholangiocarcinoma patients. And I think it's really important that although it's currently only licensed for recurrent disease, it's still important. Okay, so it's licensed for recurrent disease and patients who we don't consider for surgery. So it's crucial that we refer these patients to the oncologist so they can be considered for targeted therapy. So what are the challenges for targeted therapy? I just thought I'd show you this picture. It's a brilliant picture to just show for all the different types of cholangiocarcinoma. Just look at the different types of mutations. So, if you look at the percentage of each mutations, they're all small numbers. So it's very difficult then to have good evaluation of each mutation. And that is the current problem we face with cholangiocarcinoma. The mutations are huge. So why is there poor adherence to guidelines? Have we ever wondered why we're just not following them? Is it traditional thinking or is it just the way our center works? But if we look into the guidelines that have been published, both ESMO and the BSG, a lot of the guidelines are based on retrospective studies on national registries. The amount of randomized trials quoted in this references in these guidelines are extremely small, and it's mainly in the adjuvant chemotherapy section where BILCAP and the ESCOT trial stands out. And what we have to also accept is that cholangiocarcinoma is relatively rare in the Western part of the world. Now, if you go to the eastern side, especially in Northwest Thailand and Laos, they've got a huge amount of experience in dealing with this. However, the healthcare service is not as sophisticated as ours. And what we must never forget is that most patients present with advanced disease. So in managing the majority of patients, the oncology section is really important. I just thought I'd touch on one slide about transplant oncology, because nowadays we are considering transplantation for certain cancers, and intrahepatic cholangiocarcinoma has been considered. So, but the International Transplant Society has clearly stated that liver resection is still your treatment of choice for resectable intrahepatic cholangiocarcinomas. So please never forget that. That is the key, right? However, in unresectable advanced cases, they can be considered for liver transplantation following a strict neoadjuvant therapies, and patients have responded to that. What we have found in studies that patients who do best are patients with tumors which are less than 2 centimeters in size in cirrhotic liver. That is the current evidence. So if you've got patients with intrahepatic cholangiocarcinoma less than 2 centimeters in cirrhotic livers, they can be considered for liver transplantation. But let's not forget, it's like finding a needle in a haystack. That is the one thing I would say about the transplantation program for intrahepatic cholangiocarcinoma. So what are the learning lessons? So tumor biology is king. We cannot run away from that. preoperative staging is crucial. We need to identify patients which are truly resectable, where we can prolong their survival. Surgery is definitely suitable for selected cases. And never forget, adjuvant therapy is recommended and should be standard of care following surgery. And if we're going to make a big difference in the UK for survival of these patients, we've got to adhere to guidelines. Thank you for listening to me this evening.
Thank you so much. That was a really fascinating and comprehensive summary of everything going on in the management of intrahepatic cholangio. I would encourage any attendees to put questions in the Q&A. I have a couple to start you off on, Prof. Gomez.
Okay,
From Andy Smith, why do you think PET-CT usage is low and variable? Is it a capacity issue or questions over the evidence base or change in management?
so I think it's probably multifactorial. Thanks, Andy, for that question. It depends which center you're working at. I'll be honest with you, like in Nottingham, we use it selectively. So if my radiologist tells me in the MDT that you should get a PET scan for this patient because we have seen something not quite right here in the lungs or something not quite right here in the peritoneal area, then we will get a PET scan. But in a lot of centers also, they just do it routinely. So it's part of like the CT MRI sequence. So CT MRI and PET. If we look at the actual papers that have been produced on PET scans, I think there's good evidence. But again, it's all based on retrospective studies and on large national database or registries. There's no randomized trials to show whether PET is better. It's not like PET panc in pancreas cancer. We just do not have that in cholangiocarcinoma. So it could be a bit of both that people still don't think that PET scan is required if you've got radiologists who report CTs and MRIs sufficiently.
Excellent. Yeah, I mean, are we in my center, we also use it selectively. Following on from that, given the variation in practice that you've demonstrated, do you think that management of intrahepatic cholangio like HILA should be centralized or subspecialized, even within tertiary centers?
So this is a tough one because it's very political. So if we look at the number of HILAs we do in the country, most centers do 1 to 3 HILA cases per year. And there's only about maybe 4 or 5 which do more than 4 resections a year. If we look at intrahepatic cholangios, it's the same. Okay, so most centers do 1 to 3 resections per year, and there are just about 4 or 5 centers which do 4 or more. So we've got to think very carefully how much more we want to centralize services, because if I look at the Nottingham area, we've got patients who travel 2 hours to get to us. Now, some of these patients may then decline treatment if they have to travel further for treatment. So we've got to be very careful, because all hospitals, our workload is still predominantly emergency services. And all of us hospitals are facing a big emergency admissions. And whether we like it or not, cholangiocarcinoma just makes up a fraction of our practice. And I don't know how much more do we need to centralize care for this disease. What we are better off doing is centralization has already occurred now in the UK. We've already got our dedicated centers, and they've been put in regions to cover that population. What we are better off doing is to start off by educating each center and I say this in the most polite way and humble way, is educating each center to follow the current guidelines that is there. So let's just standardize practice and help each center getting to that, you know, uh, good level of every patient gets the same care. And I think that is what we should aim to work towards to, rather than focusing on super centralization further.
Great, thank you. Um, Another question here about thinking about R0 resections, but the quick recurrence of the disease. Do you think there's any role for the resection of stable liver recurrence if the future liver remnant would be sufficient?
I mean, I will never say never. Uh, and I think one of the things with cholangiocarcinoma is we just don't know. All we do know is that the reality is it's aggressive disease and it does come back. But nowadays, we do have very good targeted therapy. And actually, targeted therapy now does help with stabilizing disease. So maybe in the future, there is a possibility that, if you've got one solitary recurrence, which has been stable for 6 months, 8 months, you could maybe justify resecting that. However, we must not forget that these patients in the older age group, they have comorbidities, they have been through a lot. And once they have had quite a bit of chemo and targeted therapy, their liver function is not that great. So depending what kind of resection you do, you may compromise their liver function. Just something to be aware of.
Absolutely, absolutely. Um, Another question about lymphadenectomies from Michael Freitas. Do you alter the extent or type of lymphadenectomy if you're looking at right-sided versus left-sided intrahepatic cholangiomas?
I think there was a study published by the Japanese about that in terms of how radical they do their lymphadenectomies. I think in terms of standardizing lymphadenectomy, the main thing is anything from station 8 all to the way to the porta, that should be removed, and occasionally retroduodenal lymphadenectomies. I think just make it standard, whether it's right or left-sided intrahepatic cholangiomas. I think the whole point is to get more than 6 lymph nodes. So I think that is the key. It's not sampling, it is formal lymphadenectomy.
Okay, great. A question from me. You were talking about indeterminate lesions and the importance of trying to get an accurate radiological diagnosis so that you can plan for that lymphadenectomy. Well, what are your feelings about gaining tissue and liver biopsy to confirm the diagnosis and what that might mean also with neoadjuvant therapies coming on board?
I think because the disease is so bad, I think liver biopsy is definitely a contraindication. If you're going to resect it, you might as well take it out. I think if the radiologist suspects that this is intrahepatic cholangio, there is no harm doing a lymphadenectomy. As we have shown in the studies, people who can do lymphadenectomy, there's no increase in morbidity.
Okay. But if we were going to start giving neoadjuvant therapy in these cases, wouldn't we need tissue diagnosis first?
Yeah, so I think with high-level cholangiocarcinomas, the ones being considered for liver transplantation, they definitely do need tissue. I think with intrahepatic cholangiocarcinoma, I think it'll be quite hard to justify
Mm,
uh, biopsying this, because if you end up biopsying it and you cause needle seeding, no amount of neoadjuvant treatment is going to treat that.
yeah,
So I think we have to be really careful here trying to biopsy
yeah.
intrahepatic
So
cholangiocarcinomas. We cannot treat it like the hilers.
no, okay, that's really helpful. Right. Well, one final very short question, and then we really must close. Just wondering, Adam Bryce is just wondering if you surveyed fitness assessment practices and any difference in the use of CPEX or pulmonary function tests prior to.
So, so, so in Nottingham, in general, everybody over 70 here gets a CPAT test. We do it as routine. And it may just be our demographics, but most people above 70 in the Nottinghamshire area and our region tend to have comorbidities and are generally not fit. So we do tend to use CPAT as a routine. Anyone above 60, it all depends on what their background fitness is. But here we do have a very good CPET test facility, and we do use it routinely. I think it's brilliant in terms of determining whether somebody is fit enough to undergo major surgery, especially now with the use of targeted therapy. If they're not fit for surgery, you can still send them for targeted therapy as it does improve their survival.
Okay, that's wonderful. Well, thank you so much, everyone, for making their time tonight. And Professor Gomez, that was a really excellent summary of the latest evidence in a very complex and specialist area. I'd like to remind everybody that the next in the series is occurring on the 26th of November, where Sherez Marker and Lizzie Smith will be talking to us about updates in the management of gastric cancer. Thank you very much, everyone, for your time, and good night.
Thank you. Have a good evening.